Hey everyone. So today I have the pleasure of interviewing Dr. Dany Hanna. He's a urology and plastic surgery specialist who provides gender-affirming surgeries and exclusively works with trans and non-binary individuals. He currently works at the Hanna Gender Center in Frisco, Texas, which he founded in 2021. Thank you so much for taking the time to join us today, Dr. Hanna.
Thank you, Chloe. My pleasure.
So kind of just starting, I always like to just start like kind of big picture, wanting to hear a little bit about like how people get into why they're doing what they're doing. So could you tell me a little bit about like your path, what brought you into urology, plastic surgery?
Yeah, it's a really it's a really asymmetric path throughout. I was actually a business major in undergrad. I decided well after I got that, at some point when I was in the service that hey, I got to do something more. So, I decided to go to med school. I decided pretty early on I had to be a surgeon. Like that was the only thing I was going to do. So I stumbled upon urology. That was really nice. And in training, I had exposure to these procedures. And it was just one of those things I gravitated towards. I found that the patients were really appreciative. Um, I felt like with every surgery, we really were making a difference. And I was like good at it. I was good at it. I felt like I connected with the patients. It's still a brand new field. So for all those reasons, that was really my path to it. I decided very early on, if you're going to be good at something, you have to do that and only that. Can't do anything else.
Hmm.
So I made the start, or I made that the decision rather that I was only going to do trans and non-binary procedures right out of the gate, out of fellowship. That's it. And even after that, I'd gone to Europe, I'd gone to Serbia, to Germany to learn some pretty advanced techniques after all the training that I've received domestically. And we decided to move, my wife and I here to Texas because it's just, I think across the country, as you know, the trans non-binary community is chronically underserved. That's especially the case here in the South Central U.S. So I thought, what the heck? Let's just give it a go. Let's see what happens here in Texas. And fortunately, we've been given a wonderful reception here. So,
So, part of the reason for going to Texas is just to like really open up more accessibility for
oh,
services.
oh no, that was the only reason.
That was the
We
only
have no
reason.
fit. We had no family, no friends here, nothing. I think I'd visited Texas maybe once or twice before. My wife's from overseas, so she's got no family here in the States. So we threw all of our eggs into one bucket. Is that the
Yeah.
phrase?
Eggs into one
Yeah.
basket or
Eggs in
yeah, so I wonder if you could give just like a brief overview for anybody who's like maybe not familiar with your work, like the
Mhm.
surgeries, the procedures that you provide for trans and non-binary people.
Yeah, sure. So, I do, vaginoplasty is by far the most common procedure I perform. And we do a lot of vaginoplasties. And by we, I mean me. I'm the only surgeon in my practice. So lots and lots of vaginoplasties. I do top surgery, bilateral subcutaneous mastectomies with nipples or nipple sparing. I do breast augmentation, essentially run the gamut of metoidioplasty from simple to the super complex abdominal phalloplasty. And I've become somewhat of a go to center for genital nullification for patients with
Hmm.
genital dysphoria. So that's a really unique procedure. For example, vaginoplasty, there's no template, but there's like a template. Everyone does get a customized procedure, but it's a variation of more or less the same procedure depending on the patient's anatomy, their desires. A genital nullification procedure that's just a really unique one because everybody that comes to me just has a different type of dysphoria, and we're having to navigate the reconstruction to preserve, one organ while removing another in order to give the patient the functionality and aesthetics that they're looking for.
So like I'm sure like as you know, like getting surgery is a very vulnerable experience for so many people. I think even more so for like trans people, non-binary people. What are some of the things that you do to make practice and your approach to pre-op, during care, post-op care, like comfortable, safe, helping trans people feel that they're like heard and taken care of?
Yeah, sure. Well, for one, I think the number one thing we do is we only take care of trans and non-binary patients in my practice. We don't operate or take care of cisgendered patients. Now, if I have a cisgendered employee who, something comes up, I'm happy to provide advice. That would be like the only exception, but the entire office is built out to serve this community. So, I do live in Texas. So, outside you wouldn't necessarily know this is a gendered center, and that's by design for
Hmm.
safety. But when you walk inside, it's unmistakable where you are in big 3D letters, gender center. We have gendered rooms. I have trans feminine rooms in my practice. I have trans masculine rooms in my practice. We have non-binary rooms in our practice just to make the patients feel more comfortable. So the wall art, the wallpaper, the ambiance is there to to make the patient feel more comfortable in what often is an uncomfortable interaction. You're here to get healthcare. You're here to get, surgery. And for the most part, most of these patients have had, negative healthcare experiences in the past. One of the other things we've done is we've made a big investment in lasers and other devices. We found that a lot of times if patients are going out there to get laser hair removal or other cosmetic things, they have to go to these med spas that are taking care, 99, upwards of 99%, cisgendered patients. And, these patients will get weird looks in the waiting room. So we created a med spa that specifically caters to the trans and non-binary patient. So, from the second we walk in to the second we go home, that's the population we focus on. And I think by doing that, we are able to make it a more comfortable environment.
That's definitely taken me back to some of those med spa places I've been to where I was often one of the only trans people there. And some of the people I worked with were great, some were not. And it's kind of just like hit or miss. And then you don't really even know until like you're in a very vulnerable position oftentimes. So I think
Yeah,
that's
yeah.
super important to be able to provide that.
And that's just the esthetician you're working with. What if you're stuck in the waiting room and
Yeah.
somebody's just, giving you the side eye, like, what the hell is this person doing here? Nobody wants that
Hmm.
when you're about to undergo a medical procedure, even if it's non-invasive. You want to feel comfortable where you are. So our core mission is, serve the trans and non-binary community. And that's how we approach, you know, everything in my medical practice.
So kind of thinking of like as we're talking about hair removal, like what's your perspective or approach to like hair removal before bottom surgery? Because I've heard different things from different surgeons in terms of like it's
Mhm.
required or it's not required or it depends or and kind of like because there's that fear of like what if the hair regrows inside the vagina?
Yeah, sure.
And obviously we don't want that.
I would say a vast majority, 95, probably more percent of my patients are not required to get laser hair removal. There's a very specific or electrolysis. There's a very specific subset of my patients that are required to get some sort of preoperative hair removal. And that patient is the one that has really dense hair growth along almost the entire existing genital, the shaft. Okay.
Hmm.
That's really the only patient that needs it. Otherwise, we, do intraoperative bipolar epilation on any skin surface that's going to end up within the vaginal canal. And, not to get too graphic here, but when we remove that skin graft and take it to a back table, we can see all the follicles, remove them, and essentially ablate them using just high power electrocautery. And we target the areas in between the follicles too, in case there's any dormant follicles that haven't, shown themselves. And, what's our success rate? I don't know that I've ever had a patient come back to me and say, I have a follicle inside the vaginal canal. I'm sure, maybe it's going to happen. I'm sure it will at some point. I plan on having a very long career, but I haven't seen it yet. And when you're talking upwards of 99+% success rate, that's, you don't even get that with laser hair removal or electrolysis. So I would say it's equivalent. For those patients that do have a little bit of hair that's creeping up on their genital, that hair I tend not to ablate, only because then you compromise the flap that's going inside. You get really bad
Mm.
wound complications. But that hair along the proximal genital, the proximal shaft, ends up being external just because of the way I create my neovaginal lining. Not to get, yeah, I don't know if you're going to cover this, not to get too far ahead in the conversation, but I do, complex flaps with, tunica vaginalis just to give the neovagina, so, more moist, natural kind of quality. And that affords me a little bit more working room in there. So I don't need to put the entire penile shaft in there, especially the part that's hair bearing. So it's never been an issue. And you know what? Here's the other thing: not everybody has access to somebody that only that operates a trans and non-binary only med spa. So they don't want to go out there. They don't want to
Yeah.
spend the money. They don't want to go through the uncomfortable process of and expensive process of getting laser hair removal and electrolysis. And they, in my opinion, they don't need to, but that's just because of the way I do the surgery. There's some surgeons out there who have very unique ways of doing their procedure, and they absolutely do need their patients to get it. And if that's, the surgeon you have access to, then you should listen to them.
Yeah, because I mean, I think if we can save the hundreds or thousands of dollars, because that stuff is not cheap.
No. And you can't put a cost on the discomfort.
Mm.
Financially, it's costly. And then there's
Yeah,
the
yeah,
discomfort element of having to, one, go through the procedure, and two, expose yourself, and it's time consuming, and not me.
yeah. So kind of like as we're diving more into talking about, bottom surgery, vaginoplasty, can you start kind of like with a broad level overview of like what the process might look like from like consultation to, surgery to post-op care? It's like I
Hmm.
know the specifics will obviously vary from person to person, but kind of like maybe a big
Yeah,
picture.
sure. Sure, I'm happy to talk you through it. So, generally somebody would contact, start the process. You'd contact my office by phone or, inquiry online. You get a consultation. And then my patients who are local, can come and see me in person in my center for an in-person consultation. I would say most of my patients do come from outside of Texas. Some of them do fly in for the consultation, but a vast majority of them choose to do it, virtually. So, like for my European patients, for example, or Canadian patients, they're not. I've never had one of those patients fly in for a
Yeah.
consultation. We'll do that virtually, and then they'll come in a few days early. And by the time they get to surgery, we've worked them up, and we'll coordinate with their local physicians to get anything they need. But yeah, not to digress. We'll have they're generally about 45 minutes plus minus. It's really
Mhm.
organic. The consultations take as long as they need. And I kind of let the patient guide that discussion. There's certain things I absolutely have to talk about. And during the consultation, I'll ask the patient a bunch of pertinent questions that are important for me, to figure out where the technical limitations of what we're able to do together are. And, because I do so many vaginoplasties, I find that patients generally have similar questions. Most patients have one or two questions that are just I haven't heard before, and every day I'm learning something new and hearing different questions. But because of that, I put together a whole presentation that will take the patient through the process from start to finish. So What happens after the consultation? Well, you're going to have to schedule surgery, and you're going to have to get these labs and then surgery, and here's the post-operative process and blah blah blah. And that's essentially the consultation. So after that, I'll generally give an idea to the patient of what the wait list is like, and we'll typically have we'll typically cancel one or two patients a month, sometimes more, sometimes less, just for a variety of reasons. There's medical issues that come up, there's other issues that come up. And because of that, for the really motivated patient that has, the required letters, and if they're, really ready, we can sometimes squeeze patients in within, a 6 to 8 week time frame, which is,
Wow.
that's not common, but we can absolutely do that sometimes. When the patient schedules, regardless of when that is, that starts the pre-operative rat race. So they're assigned a patient care coordinator within the office. We'll send the patients a really dense pre-operative packet for them to read. And that takes them through the whole process, lots of consent, gives the patient a packing list, an idea of what to purchase. And then we'll take them up to the day before surgery, what they need to do. So, and we'll kind of guide all of that. We'll do all the insurance pre-authorization for the patients. The only thing that they need to do is supply us with the letters. And if there's other insurance requirements that we need from the patients, we'll just get in touch with them. But we're really going to hold the patient's hand from start to finish. Coming up to the week of surgery, in the day or a couple of days before surgery, we have the patients institute this is for my bottom patients, clear liquid diets and bowel
Mhm.
preps just to get them ready for surgery. The hospital will call them, let them know when they need to come into the hospital, because I typically do more than one case every day. So then they will come to surgery. I'll greet them in the preoperative area along with my entire surgical team, my first assists, the nurses. They'll have the surgery. And then afterwards, my bottom patients are admitted to the hospital. I have a whole transgender wing for my patients. The rooms are large, they're private, meaning they'll be the only patients in the room. It's really more of a hotel than it is a hospital. I've trained all the nurses myself. So the
Awesome.
patients will be very comfortable. And if they have a guest that's staying with them in the hotel room, they can expect to be very comfortable as well. I would say the average length of stay is maybe about 5 days or so,
Okay.
plus minus. It's rarely less. It's also rarely more. So I would say 5 days is a good gauge. Typically, patients will then go back to a hotel, Airbnb, their apartment, their home, and we'll usually arrange for a visiting nurse to come say hi a couple times during their stay, just to check on them. Patients will then come back to my office about 1 week after surgery. So, for example, let's say, today is Tuesday. If you had your surgery today, you can expect to come back to my office next week, Tuesday, for follow up. And that's generally when we get the drains, tubes, and packing out. If the
Okay.
patient's going to dilate, we'll, supply the dilators. And I will first dilate the patient, give meticulous instructions, and then I'll watch the patient dilate in front of me because I don't make house calls. So I need to make sure that the patient knows how to dilate. And then we'll take the patient through the rest of all the post-operative stuff that they need to know to succeed. And then, patients will typically stay in the area another 24-ish hours or so if they're traveling from afar, and then they'll leave, and we'll do all of our subsequent follow-ups that are spread out, depending on what's going on with the patient, typically at 1 month, 3 months, 6 months, sometimes out to a year. And that's really it. But all my patients know that, I take the patient physician relationship very seriously. And if they need me at any point for anything, we're always here for them.
Yeah, sounds like a
I
very
would say that's the
thorough.
process in a nutshell. Well, you have to be. This isn't
Yeah, exactly.
you're not removing a mole here. This is major reconstruction. And depending on the technique that the patient chooses, there's some serious lifelong implications.
Hmm.
Healing may stop at, you know, 1 year, 18 months, 24 months, whatever that the particular healing process is for that specific patient, but you're always changing as a person, as a human being. Your anatomy is always changing. You know, there's not many of us out there who do these procedures. So new things will come up and, you know, new concerns. So, you know, I just want to make sure that we're available to help patients navigate the nuances of their specific anatomy, just so they can live life as, you know, being the best version of themselves. That's it. That's all we want to do.
Yeah, absolutely. Making me wish my process was as thorough. But neither here nor there. Um, yeah, couple of questions of some of the stuff that you brought up. Kind of going back to the consultation piece. What are some of those like pertinent questions that you mentioned? That like some of the questions that you like, these are the questions I will always ask, like for people, because you mentioned like you have pertinent
Yeah,
questions.
yeah. So, you know, here are the questions I always ask. I always, you know, I always ask about, I always ask pronouns. I always ask gender identity. Those are the first things I go through. I always ask about transition, the process, how it was, time frame, when did it occur, hormones. I always ask about prior procedures, medical history, current medications. I always inquire about HIV status. Not that that's going to disclude a patient, but patients with, you know, HIV have very specific concerns that, you know, we need to take into account for surgery.
Hmm.
Diabetes, very important. Any nicotine use prior, if a patient's received a Gardasil shot, do they have a history of HPV? Very important. And I want to know if I also want to know if patients have had prior orchiectomies,
Hmm.
because that does affect me specifically with my technique again, because I do utilize a tunica vaginalis flap again, which will give that vagina that natural moist kind of quality, theoretically at least. And depending, you know, if I did the orchiectomy, I know what tissue I preserved, I know it's done, you know, I understand the genitals, so I know where to grab it for the vaginoplasty and how to interpose that. But if another surgeon has done that, you know, that can present some issues because those surgeons don't do vaginoplasties and they wouldn't necessarily know, hey, let's preserve this tissue because Dr. Hanna, you know, wants to do it for this. If those surgeons even know what the, you know, tunica vaginalis is.
Can you talk more about the tunica vaginalis flap in terms of the
Yeah, you
procedure?
know, tunica, you know, so as, you know, when you're in the womb as a baby, you know, your testicles actually start in the abdomen and
Hmm.
they gradually descend over time into the testicles and are attached to a structure called a gubernaculum that helps tether them to the bottom of the scrotum. And they drag layers of the abdomen like peritoneum and muscles and all these things with them. And the tunica vaginalis is one of those layers that has that nice peritoneal like quality. And the reason
Hmm.
I like using it over something just like harvesting peritoneum is I can, I'm going to get a little technical here. I'm sorry. Stop me. You know,
Go for
I
it.
stay retroperitoneal. I stay outside of the abdomen, which for me is critical. Any surgeon who's ever operated in the abdomen knows to respect the abdomen because once you get into it and once you violate the peritoneal space, there's potential lifelong consequences of that, even if you've had a perfect surgery. So the reason why I like taking that tunica vaginalis is I can get, you know, similar tissue outside of the belly with minimal risk and use that.
Hmm.
So that, and that's why I like using it.
So you like get the benefits of like peritoneal tissue without the risks of going into like the abdominal peritoneum.
That's the theory behind it essentially.
I guess could you talk a little more about like your typical approach? I think as you've mentioned, like the penile inversion is kind of
Mm-hmm.
the most common approach that you utilize. I wondered if you could
Yeah,
speak
I
at
would.
all to like the other approaches as well. Like,
Yeah, no, I can. So we do offer PPT, although it's rare, mostly because of technical limitations. There's, you know, you need a robot to do one.
Mhm.
And not that it's a two surgeon surgery, but it does require more staff, more resources. So because of the increased resource burden, there's limitations to, when we can perform that surgery. I think it's a great procedure. My bias, and, this shouldn't, I want to be very careful. I think the PPT is a great surgery, and I think there's really great surgeons doing that surgery. For me, I think the PPT is really good as a revision procedure. So if somebody
Mhm.
loses depth, something happens, you have this virgin abdomen you can then go into and use this on ideally unharvested tissue to then go in there, open up the old canal and use the peritoneum to line, open back up. That's when I think the PPT is great. I think again that, a penile inversion is great because the depth is equivalent. Again, you're completely outside the abdomen, so you mitigate the risks of any injury to any intra-abdominal organ at the time of harvesting a flap. Organs such as a small bowel, large bowel, stomach, pancreas, kidneys, adrenal gland, any liver, any of those organs. And not just that, there's always a risk of small bowel obstruction. So, you know, if you've ever had a cut, you've ever had an incision, you can look down at that skin, and where you had that cut is different. That the skin looks different than everywhere else. That's called a scar. Well, the same thing happens in your abdomen. Anytime you get into the peritoneum, you develop scar tissue. The problem is you can't control how that scar tissue formed. Sometimes it can attach to your bowels, it can twist them, cut off the blood supply, or pinch off the small bowels and the colon, and that can, cause backup and all sorts of life-threatening issues. It's not common, but it's it's a real thing. The number one cause of small bowel obstruction in the Western world is prior surgery. In the
Mhm.
third world, it's things like worms, parasites. But in the first world, where we have access to surgery, it's the number one cause of it. So I do my best to stay outside the belly, and that's why I utilize a penile inversion. Now, as far as my typical technique, I will always talk to patients about what their goals of care are. How much depth do they want? Do they want to focus on, cosmetics? Do they want depth? Do they want to focus on both? And that will more or less dictate how I place tissue, where I place tissue. And there's all sorts of different variations of these procedures. There's full depth, there's minimal depth, there's penile sparing, there's testicular sparing, there's a wide variety. There's sigmoid
Mhm.
interposition or colonic interposition. So that's certainly also an option for patients to go with. That presents similar, to me, any sort of colonic interposition also presents similar risks or increased risk of intra-abdominal surgery with the added risk of harvesting bowel and fresh suture lines on the colon,
Mhm.
which increases the risk of, stool leakage in the belly. And you're also harvesting bowel. So if you ever need bowel for anything else in the
Yeah.
future, like, you're working on your back foot.
Okay.
So they're good procedures. Like if that's what you have access to, like go and get it. I don't want to,
Mhm.
I'm not here to talk you out of doing those procedures, but I love the penile inversion. To me, it's the gold standard. And that's why I do it.
Yeah, that makes sense. And it sounds like for like if somebody was coming in for a revision, like wanting more depth, like a loss of depth, like
Hmm.
the PBT would be like
Hmm.
kind of the go-to for you, or
Not
because
necessarily the
okay.
go-to, but it's I always keep that procedure in my back pocket, and we pull it out when we're ready to go. I think it's a spectacular procedure, first vaginoplasty, but more so for a revision. I think it's a great procedure.
Mhm.
I think penile inversion or not penile inversion, I guess at that point it's not a penile inversion, but a retroperitoneal approach to um, increasing depth during a revision is also an option. You just got to be really careful with revisions, regardless of the technique. There's always increased risk of bowel injury and wound
Mhm.
complications. So it's that's truly a procedure that's like patient dependent. You got to look at the
Yeah.
patient's anatomy and figure out what technique is going to maximize their benefit while minimizing their risk.
I guess I just had like one other like logistical question, like
Yeah.
in preparing for surgery. I've heard like there's like various timelines in terms of like what surgeons recommend for like going off of like estradiol or even testosterone blockers. And I'm wondering like what your approach to that is. Like, what medications would you recommend patients to go off of and
Mm-hmm.
for how long?
Mm-hmm. Yeah. So the first, so first, nicotine. You got to
Mm,
stop using all nicotine products. For me, preferably 3 months before surgery, but
okay.
really like for life. Just nicotine is just all bad for wound healing. So that's the number one way you can guarantee making your healing course a little bit difficult. As far as hormones, I don't require patients to stop testosterone before or after surgery. Spironolactone, I have patients come off 2, 3 days earlier, only because I don't want it to mess with the fluid dynamics, specifically for anesthesia. So I only have patients come off of Spiro like a few days before surgery. As far as feminizing hormones, the only time I have patients stop feminizing hormones is if they're oral or rectal. So you
Okay.
got to stop doing rectal hormones because they're more or less in the area of surgery. I don't want it to cause any problems. But also oral because of the specific risk of hematologic or blood issues with the oral hormones. If a patient's on injectable or whatever it is, any other type of estrogen or progesterone, they can continue that, through the whole preoperative process. They don't need to stop.
About how long would they go off of like the oral hormones? Is it a couple
Yeah,
weeks?
but no, 1 week before, one
Okay.
week after.
Okay.
And I say 1 week after because, that's when all the packing comes out, all the drains, the tubes, any additional dressings that's on there. That's when the patients can physically be more mobile because I've taken all of my stuff off of them. They don't, they're not carrying around all these things.
Question that always comes up is like cost. So I was kind of wondering, I know like the cost can vary greatly because it's very, tailored to the
Mm-hmm.
individual.
Yeah.
But I'm wondering like in what ways do you work with patients to help like navigate insurance to help make things more feasible? Like, because I know some like surgery offices have teams that are more experienced or less experienced in like navigating the intricacies of getting gender affirming care covered. So I was wondering what patients might expect.
Yeah, so a patient can expect when they schedule surgery with us, we will do everything from start to finish to get them through surgery. We require very little of our patient, only essentially the bare minimum. So, insurances, they typically lag behind WPATH guidelines, whatever the insurance requires, whether it's one letter or two letters or three letters, that's what we ask for the patient. So they have to get those to us. We need patients to upload their insurance card and give us their, membership numbers and all these things. Other than that, my team will do everything for the patients. If there's peer to peers, we do that. Essentially, anything that's required to get the patient from consultation to surgery and get the surgery paid for, we're going
Mm-hmm.
to take care of that to the patient to put as minimal burden on them as possible. I mean, the process is stressful enough, so we do our best to make it as easy as possible. But no, we have a very experienced team that will do everything we can for the patients. And it's one of those things where sometimes it's explicitly stated in a patient's policy that surgery is covered, and then the insurances will come back and say, well, no, 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 it's only covered under these circumstances. And, then we have to go through the rigors of the peer-to-peer process. And sometimes it'll come down to like the 11th hour. There's a procedure I did 2 weeks ago for a patient, a bottom surgery. And the day before surgery, we got approval at 4:45 p.m.
That's
Crazy.
so
Patient had
stressful.
made travel arrangements and all these things, but that's what these companies do. But we'll fight up until the last minute. And if it comes to pass that the patient, needs to be pushed because their insurance is being difficult, we never push patients to the back of the line. I'll just
Mhm.
add an extra operative day or stay later to
Okay.
accommodate the patient within a reasonable time frame. Usually within, like, as long as a patient can make work and personal arrangements, I'll often accommodate patients within the month.
Okay. Yeah, that's really good. Yeah, because I know that's incredibly stressful, just waiting
Oh my
for
God.
the insurance to give the yay or nay. And
Crazy.
it often takes like, why does it have to be so close to the surgery?
Chloe, 4:45. I'm not,
That's
it may have been 4:46. I may be a
and
minute
the
or two
surgery was
off.
like the next morning.
It was the next morning.
Oh
She was the
God.
first one. She had to be at the hospital about 13 hours later, 5:30, 5:45 a.m.
God, that's awful.
It's crazy. It's crazy. That's what they do. I don't know. I don't want to speculate. I don't want to speculate. I can't. I can't speculate.
Yeah, we could probably be here all day doing that.
Be here all day and get in trouble, and all of a sudden I'm getting contacted by lawyers of these insurance companies. I don't need that.
So I guess kind of as like a final question, for anyone who watches this, anyone who is watching this and is looking for, gender affirming surgery, are there any closing words that you'd kind of provide that would maybe be like why they would want to consider you?
Yeah, just look, this is literally all I do for a living. I only operate and work with trans and non-binary patients. I'm a board certified urologist. I'm fellowship trained in gender affirming surgery. I've done additional training overseas. We're high volume. We're doing hundreds and hundreds of cases every year. I'm good at surgery, but if something happens, and things inevitably happen from time to time, I'm also really good at managing complications. The other thing is, like, I don't abandon my patients. If you need me, I'm there by email, I'm there by phone. You can always come in, and we're, here for the patient from start to finish. But that being said, I am only one person. I can only do hundreds of procedures every year. And if somebody has a surgeon that's very close to them that also does a good job, you know, they may also be a good surgeon too. I I just told you my bias for my procedure and
Hmm.
the penile inversion, why I love it so much. The reality is, what procedure is best? The one you have access to
Yeah.
and the one your surgeon is really good at doing. That's the best one. I'm just a cog in the wheel of the transgender health community. I'm just trying to increase access to care and trying to make life livable and trying to get patients to be the best possible version of themselves, like many of my peers.
That's wonderful. So, any final words or anything else you'd like to share about you or the work you do before we kind of wrap up? Anything we didn't touch on, or just any closing comments?
I can't relate on a personal level what the transition process is like for you and and a lot of your viewers. I can't imagine living in the wrong skin my entire life. I mean,
Mhm.
I'm a hetero cisgendered male, and my life is incredibly stressful and complex. If I had to throw gender dysphoria on top of it, I don't even know what. If I had any hair, I would have ripped it out, a long time ago. I would say just hang in there. I'm not the only one out there. There's many more like me who want to help. Um, you got to hang in there and find us, and we're here to help you.
Well, thank you again so much for your time and for being here today. I hope this is really helpful for all the people who end up watching it. I'll
Thank
go.
you. It's my pleasure.
Yeah, of course. Yeah, I'll go ahead and put like information for, your website, how people can like, learn more about you, like in the description below. If they're interested in reaching out for a consultation based on what they've seen today. Yeah, who knows? So, I'll put that information so it'll just be like easily accessible for everyone. But, in closing, thank you everyone for watching. Hopefully this is informative. as always, be sure to like the video, share with anybody you think might benefit from this. And, my cat Tipsy and I thank you all so much for taking the time to be here today. And thank you again to Dr. Hanna. All right.
Thank
Bye
you,
for
Chloe.
now.
Bye.